Welcome to the 4D show, that is detailed discussion diabetes of Indian diabetics. This is the 49th episode of 4D show and we are very excited to be here. We are so thankful to all of you for your continued patronage and support, without whom even one episode of that would not have been possible. So we are looking forward to the golden jubilee of our 4D show next week. So please stay tuned for that. Today we have a very important topic for you and us to discuss and learn together, which is the blood glucose management the end goal of diabetes management? We know that vast majority of patients with diabetes, they stay uncontrolled. If you look at statistics, majority of patients with diabetes are not able to achieve their glycemic target goals of 7%. Very important for us to understand is that that is not the total part of the story. If you look at the comprehensive picture of A, B, C, and if you put W into that, that is A for A1C, B for blood pressure, C for cholesterol, and if you look at how many percent of patients are controlled on all three parameters, the number goes to almost like 25 to 30%, which means that we can do much more to help our patients with diabetes live a better life. We can do much more to encourage our patients to adopt healthy practices. We have a very learned guest today, an eminent endocrinologist, Dr. Sona Susan Abraham. She is trained in endocrinology as well as medicine from the best of schools in the country and has practiced in various parts of the country, North India as well as South India, and she has a lot of experience up her sleeve. I'm sure the discussion is going to be lively and enriching, and something which you will be take home, some important learning points you will take home and help your patients treat diabetes in a better manner. So welcome to the show, Dr. Sona.
Hi, I'm Dr. Sona Susan Abraham. I'm a consultant endocrinologist and diabetologist at Lourdes Hospital in Kochi. I did my MBBS from Trivandrum Medical College. I went on to the US to do my residency in medicine and fellowship in endocrinology and diabetes and metabolism from the University of Maryland, Baltimore. I'm American board certified in both internal medicine and endocrinology. I've been back in India for the last 15 years and presently at Lourdes, Kochi. So the topic for our discussion today is optimizing the blood sugars the end goal of optimum diabetes management. And why we talk about this very important topic is because the usual patient who comes to us very often, maybe even in a primary care physician's or a family physician's office, brings to us a report like this: a fasting sugar of 106, blood pressure which is fairly normal, a cholesterol report where the LDL shows up as 109, the triglyceride does show to be 249, HDL is 54, and what eventually happens in the fast-paced clinic practice that we do in India is this kind of gets overlooked. And what message that goes across to the patient is, yes, your sugar is a little borderline, don't worry, just there's no need for any medication, just do diet and exercise. And the patient puts this in his file and disappears. And sometimes this is the other presentation. And if you look at the first picture, you can see this is a patient who's now presenting you to you maybe in a health checkup, and they come to the doctor with this HbA1c of 5.3, and you say, oh wow, this is great, you're not even diabetic. But if you were to look a little deeper, if at all you were to get a fasting insulin level with the same HbA1c, you will notice that everything is not that okay as it looks to be. And what information most doctors usually get is just this HbA1c, and if they are, and very often just the blood sugar, and we make decisions based on just one point in time. And this is giving a lot more deeper insight into what is happening behind the scenes in that particular patient, who by labs isn't a diabetic or even a pre diabetic yet. So, why do we typically treat these high blood sugars? I mean, a lot of times patients talk to us saying that, oh no, you guys, you doctors are always just lowering blood sugar targets because you just want to put everyone on medications, and this is all bogus. But where did we get these numbers from, or these bars of what's the treatment bar for why have you picked HbA1c of say 7, or initially at least, as the target to treat a patient too. And a lot of that initial data came out of two big landmark trials in diabetes. One, the DCCT, which was predominantly a huge trial that looked at type 1 diabetes. And as you can see, what was found is that as the HbA1c starts to increase, the risk for, say, nephropathy in terms of microalbuminuria, neuropathy, nephropathy, and retinopathy starts to go up. And it's about 7% HbA1c that it starts to sort of splay out. And that is where, that was why 7 was picked as a reasonable target to achieve, to minimize the risk of these microvascular complications. Now, what was also found in the DCCT was when you aim to try to get the HbA1c lower, now you have to remember that at the time that the DCCT was done, we really had the older kinds of insulins, and we don't have the many advantages in terms of monitoring and things that we have today. We don't have pumps. We're really looking at the older insulins. And when they tried to get the patient's HbA1c below 7, the incidence of hypoglycemia shot up. And that is why, 7 was thought to be a reasonable enough target. Now, coming to type 2 diabetes, the UKPDS was the big study looking at type 2 diabetes, and what it found was that for every 1% reduction in HbA1c, there was a huge reduction in complications, 37% in microvascular complications when it came to kidney and blindness, 43% reduction in peripheral vascular disease, 21% reduced risk for deaths, 14% reduction in heart attacks, 12% reduction in strokes. But as you can see, the bigger change, the bigger improvement seem to be more in terms of microvascular disease rather than macrovascular disease, even in the patients with type 2 diabetes. So then intuitively, people thought, well, if we can manage to achieve a much more intensive glucose control, sort of mimicking what would be normal in a non-diabetic person, if we can get there, well, we should really see much better cardiac outcome and improved mortality rates. And that's sort of what the premise for the Accord trial was. And it was a huge trial, multi-center trial, which really looked at intensification of HbA1c targets, mostly using sulfonylureas and insulin rather. And we didn't have these newer molecules we have today. So in light of that, what they, however, found was a little bit more shocking than what they expected. And it actually showed more deaths from any cause with intensive treatment. And that led to a little bit of a rollback on saying that maybe we shouldn't really try to be too aggressive. Maybe in somebody who's older, maybe we need to individualize. Maybe in somebody with bad kidney disease, maybe we shouldn't try to go so low. We should really, maybe in an elderly, maybe even an HbA1c of 8 is fine. So then it became a lot more, lax in terms of how tight should we really aim for the HbA1c. But then all this is coming from glucose control. We are talking about glycation end products. We're talking about microvascular disease at this point of time. Now, if you look a little closely at the Accord trial, something that caught my attention was just look at the difference, okay, in the patients on standard therapy. They were people who were, on an average achieved an HbA1c of around 7.5, and those in the intensive group who achieved an HbA1c of close to 6.5. Now, for that 1% drop in HbA1c, look at what a huge difference in weight that happened over time to the tune of say 4 to 5 kgs, and which is expected because the more sulfonylurea you use, the more intensive insulin regimens you use, the risk for hypoglycemia goes up, and that in turns increase the weight. Now, what was different about now when the newer molecules have come out in the field of diabetes, especially say this is specifically looking at liraglutide, the leader trial. And what you can see is that this started showing a huge improvement and mortality benefit, macrovascular disease benefits in those who were on liraglutide. Now, this is looking at primary outcome, this is looking at cardiovascular death, this is looking at non-fatal MI, non-fatal stroke, and across the board, you can see there seems to be a benefit, which was something that we did not see in the Accord trial. So what changed? Now, looking, that is the GLP-1 analogs, the big molecules today, and coming to the SGLT2 inhibitors, talking about the MPAREG study. Again, you can see that there is an improvement. These guys came to the forefront in terms of cardiovascular disease. So to the point that cardiologists are now starting to, prescribe a lot more of SGLT2 inhibitors, and because we actually see a huge risk reduction when it comes to macrovascular disease, cardiac failure, all-cause mortality. So and these slides just show that huge difference, and this is to the tune of what effect that we would see with statins. Now, is it a class effect? Now, if you look at many of these trials, this has looked at the other GLP-1 agonists also, exenatide, liraglutide in the leader trial, semaglutide in the sustain 6, and albiglutide in the harmony studies, and every one of them shows that there is a distinct cardiovascular benefit when we use GLP-1 analogs. And my big question is how do we explain this? And this led me to kind of think about it this way. Now, if you look back at the first two patient slides that I showed you, and now when I show you this model, see what we are able to measure is the sugars. We can measure BMI, but we look at the LDL. We can try and put patients on an aspirin. We can give them a statin to control their LDLs. Maybe we can bring their LDLs down to maybe below 70. We can control their HbA1c and bring that HbA1c say below even 6.4. Maybe address the BMI, but what we do not see is what sort of what we are just picking up is just the tip of the iceberg. What we are not addressing is visceral fat. And as Indians, what is unique about us is we are thin outside, fat inside. Be it genetics, whatever it is, we tend to look lean on the outside. We pack a lot of fat, be it in our livers, be it in our viscera. And this seems to trigger the insulin resistance that we see. And one marker of the insulin resistance in the lipid profile, a clue, could be the high triglyceride to low HDL ratio. Not individually, but as this ratio, this has seemed to kind of correlate much better to the degree of cardiovascular disease, the coronary involvement, than even LDL when it comes to us Indians. Now, so again, this slide is to kind of highlight that even in this now these are looking at pre-diabetics. Okay, these are not even the ones who have diabetes for years. Now, even in this, look at the hazard ratio. The minute the HbA1c is in crossing what is sort of into the pre-diabetes range, you're almost having a double increase in risk for coronary artery disease and CVA. And if you look at the population, a vast majority of people are not even diabetic. They are just pre-diabetic, or they are just may not have even pre-diabetes, but they're insulin resistant. And we don't even have any good measures of this. They do not walk into the clinic with any symptoms, and their first presentation could be an MI or a stroke. And that's when we turn our attention. And even then, we are just looking at just managing their blood pressures, we are managing their lipids. We're not addressing the elephant in the room, which is the insulin resistance, because we really can't address what we don't measure. And I think that is where the care today is really being compromised. And this is where I think, as a nation, we need to bring our attention to and address this right here. So, what can we do for this group of patients? And a lot of them may or may not, come to the doctor's office until it's too late. But maybe at a national level, I think we really need to increase awareness. And when we talk about insulin resistance, think about it. I mean, we are already insulin resistant. If we have far more carbs, carbohydrates are converted to glucose in the body, and that will trigger far more insulin secretions. And in that process, the pancreas gets, stressed. And and this visceral fat also, when deposited in the pancreas, can actually cause a reduction in the pancreatic ability to produce insulin. So logically, what would work is a lower carb diet. And as Indians, we love our carbs. We come from a nation where carbs are our staple diet. People would be just fine having only carbs. Maybe 90 to 100% of the diet could be just carbs. We are a very protein poor nation. The fats we have is in the form of fried carb kind of fat, which is again much more unhealthier than fats alone. And so that's one approach that we need to really address and start thinking about, because a majority Indian probably eats anywhere north of 300 to 400 grams of carbs, maybe even more. So the drugs that reduce insulin resistance is the other thing that could be added to our armamentarium. And as doctors, if we don't think about addressing insulin resistance, we'll only think about we'll only think about insulins and sulfonylureas and see good sugars, and we are not using enough, say, maybe any of the insulin sensitizers like metformin or TZDs, or maybe the neo GLP-1 analogs, the SGLT2 inhibitors. And those need to be combined in the care so that we can effectively lower this insulin resistance. We also need to start thinking about how can we do a beta cell preservation by using medications, or even diets that would allow us to do that. We need to think far more seriously about weight loss, if not anything else, at least inch loss around our bellies, and exercise, be it aerobic, strength training, resistance training. All these together is needs to be addressed, and this is what we need as a nation to prevent the onslaught of macrovascular disease. And we cannot think about microvascular disease in isolation in a diabetic. We need to think about the whole patient, and just managing their labs will only get us so far. That's all I had to say. Thank you.
Any dizziness, I'm not having any headache. Why should I think about my blood pressure? Even if my blood pressure is high, why should I treat about that? An important thing to remember is that there is a lot of correlation between the blood glucose management and the management of other parameters like the management of lipids, blood pressure, weight, and diabetes. So, how does our managing of diabetes affect other metabolic parameters? How are they correlated? What are the important things a physician should know while managing our patients with diabetes so that we are able to take care of all of these aspects in a better manner?
So I think in today's day and age, we are increasingly hearing the term diabetes remission. Uh, and I think as this catches on, I think we are starting to understand, say, metabolic disease a lot better. And we do realize that, we cannot look at sugars in isolation. We need to understand what's happening behind the scenes. The high sugars. So when we come to type 2 diabetes, we are now understanding that there might be subtypes of type 2 diabetes. Some We talk about the severe insulin deficiency type of diabetes. We talk about the severe insulin resistant type of diabetes, the mild obesity related diabetes, maturity related diabetes. So all these kinds of subtypes are important to understand what we need to do. So in a large majority where insulin resistance is the bigger driver of the type 2 diabetes, lifestyle modifications may go a long way in terms of improving the blood sugars, reducing the need for insulin, reducing the need for medications, reducing the need for blood pressure medications, address fatty liver, and many of these drivers of metabolic syndrome, even including the lipids. And that is probably what the primary care physician goal should be if you are accountable for the whole patient at the end of the day. It's not just making sure, oh, your numbers are good, your HbA1c is great, that's all I need to do, your pressure is good, this is good. But if you don't address the deep seated problem of insulin resistance, I think we are going to be missing the big picture.
So, one important question which always comes to mind is that when we are trying to manage our patients with blood glucose, how does it impact the long-term outcomes like mortality? How does it lead to, the risk of complications? How does it lead to the complications being progressing? So how can we correlate those things? How can we, manage those things? And how can we manage our blood glucose in a better manner so as to decrease the risk of many of those long-term complications for the patients?
See, I think one thing which we are all on board with, and we all agree across the board, is the fact that if we can manage a low HbA1c without causing the patient a risk for hypoglycemia, that would be the way to go. And that most definitely would reduce the risk for, say, nephropathy, say, neuropathy, and retinopathy. Three biggies in terms of diabetes care. But if we can achieve low HbA1c without hypoglycemia and be able to lose weight in the process, I think that would be what would really make a difference when it comes to cardiovascular mortality, risk for strokes, risk for peripheral vascular disease. And I think as physicians, we sometimes outsource that responsibility to nutritionists. And to be honest, many nutritionists, the way they think about diabetes is make sure they have 6 meals a day, 2 rotis for breakfast, two for lunch, two for dinner. And if we do the same philosophy without understanding the baseline metabolic health of our patient, I think we would be doing the patients a huge disservice when it comes to macrovascular disease. And I think that is something where I think there is a lacuna of understanding when it comes to many primary care physicians. I think even a simple, a little conversation to the patient about the importance of reducing, say, not just sugar, but also carbohydrates, be it the roti, the rice, the bread. Even if they were to go down by even 50%, that could hugely impact their blood sugars, maybe much more than any one drug could do. And not just that, that would also improve their lipid profiles. It would also improve their blood pressure and, help them across the board. And I think that is probably one area where I think primary care physicians can do better. And to be honest, everybody is super busy. And I think the problem right now in busy practices is that these conversations don't happen. The education sometimes is a little bit lacking, and we end up managing numbers. And I think a little bit of change in mindset needs to happen if we really want to do the right thing for the patient in the long term.
In terms of microvascular complication. But that brings an important question. Can we do a subgrouping of those patients? Or maybe does a trial like cohort or a subgroup cohort like accord, you know, give us an idea about specific subgroups of the patients which probably are not well suited for intensive glycemic control, and some of those who are perhaps where it is more prudent to subject them to intensive glycemic control. So, any thoughts on the same, Dr. Sona?
See, I think the biggest unfortunate part of this is we are really lacking in data from India. We are a huge nation. Uh, the enhanced database has already shown that as Indians, we get coronary artery disease, we get diabetes at far lower, BMIs than, say, our Caucasian counterparts. And the coronary artery disease also happens almost close to a decade earlier, and it is. And that is something which I think is not getting the necessary attention that it is. And yes, looking as answering your question, you're looking at a cohort, a subgroup in terms of who would do better. I think we already know. I think the people who are on medications that could cause them far more hypoglycemia, people who are elderly, and I think the other important thing while we talk about this is also monitoring. Now, many people in India traditionally have been not very great at monitoring their sugars. The widespread use of glucometers has only happened far more recently, and even in the ones who use glucometers, many just use them just for fasting sugars, and they don't often check their postprandial sugars. They don't do a 7 point sugar anytime. Um, uh, we do have continuous glucose monitorings available today, and I think these are all tools, and we can use these tools to help educate the patient. Maybe a cohort study is not something we'll ever find, but we know the ones who have renal insufficiency, we know the ones who are elderly, we know the ones who are on these agents are most likely going to have far more difficulties in terms of getting them down to goal. And sort of trying to individualize is really the way to go, rather than whatever cohorts we get. It's just not always going to be generalizable to the population or the patient that we see, because many of the patients we see may not really ever get enrolled in a study. So we'll, at the end of the day, we'll have to use guidelines are guidelines. We'll have to use a common sense and data from each patient to guide therapy in them.
When it comes to diabetes, no discussion is complete with when it comes to diet and diabetes, and especially in our context where the diet tends to be, uh, so much rich with carbohydrates, which is, one of the culprits when it comes to increasing the blood glucose levels. So, and there have been specific dietary interventions which we all have know, which we follow in our patients. So, are there any synergistic advantages or any synergistic effects of combining a specific dietary intervention with intensive blood glucose management? So maybe, if you have a patient with, say, doing a very low carb diet, and you're targeting an intensive blood glucose control, what are the strategies you need to be careful about? What are the medication changes you need to be careful about? What are the things we need to tell about? Say, suppose if a patient is on sulfonylurea or a long-acting insulin, the patient again wants to go to an intermittent fasting with prolonged period. What are the things which we, as a doctor, need to be telling our patients about?
See, what is, I think it's a great question. And the problem is many patients are not having that conversation with their doctors, maybe out of fear, or, of being told that they're crazy or whatever it is. But I wish more patients would actually talk to their doctors and say, this is what I would like to do. How do I do this? How can you help me achieve those goals? So, if as a doctor I know my patient is desirous of going on a very low carb or a intensive intermittent fasting, I would make the necessary changes. And most importantly, I would first take away the sulfonylureas, maybe titrate up other medications, maybe use more GLP-1 analog to kind of help them stay the course. And I think and the conversations need to happen. And the thing about low carb is, say for example, somebody eats say two rotis for breakfast, or two parathas for breakfast, and if they have one less paratha, their sugar could be like say 30-40 points below what say two parathas may drive up their sugar to say 250, and one paratha might drive it to say 200. And for them to know that this can make the difference, like a medication would, and say for example they're on insulin already, if they are going on a low carb diet or an intermittent fasting, I would change them to more short acting insulins, not premixes, so that their risk for hypoglycemia goes down. I would educate them to understand the relationship between these drugs, medications, insulin, and their diet, and what is carbs, what are the things that would drive up the sugar. So I think it really comes down to educating the patient. Just handing them a sheet that tells them do this, do that, I don't think is the right way to go.
So, what are the strategies we can use uh, to improve the adherence of medications for our patients with diabetes?
See, I think again, I think education is the way to go. Very often, some of the things that prevents compliance when it comes to medications is financial costs. Diabetes is to a large extent a lifelong disease, provided you can do a lot of things differently in your lifestyle that may put it into remission. But largely we are looking at it for the long shot. So cost is an important factor, and that conversation needs to be had. So that's one thing. The second thing would be, say maybe trying to understand what somebody's lifestyle is like, when what is the likely time they might be able to eat their meals, what is the do they have flexibility, do they not have flexibility. So that would be an important factor when I plan medications or insulin, because when you customize something around the patient's existing lifestyle and make small tweaks to that, that often improves compliance a lot more than telling them stop everything you're doing, do this. They might do it for a week, 2 weeks, and but they'll eventually not come back to you and do what they were doing, and probably they'll end up running sugars of 300, 400, and come back with a stroke or an MI the next time. So I think listening to the patient, talking to the patient, explaining to the patient, educating the patient, all these are important factors when it comes to compliance. Sometimes when you think about a patient who you think is labeled a non-compliant patient, sometimes a conversation, maybe there's something going on in their life, something that's going on in their relationships, something that's going on in their family, their work pressures. Not Nobody wants to do a bad job, nobody wants to have bad sugars, but sometimes they're just not able to because they're barriers, and understanding those barriers as their doctor and helping them address those barriers are also very important aspects when we talk about compliance.
And these are some of the key takeaways which we should carry home today. And we this will help our listeners, our doctors, friends to take care of their patients in a better manner. So any recommendations, any concluding remarks from your side, Dr. Sona?
See, I think as doctors, when a patient walks in, thinking about the glucophenotype of a patient, in terms of, are they more insulin deficient, are they more insulin resistant, what is the room for improvement when it comes to lifestyle, what is their likely insulin resistance, and if in if we factor all those things, we might be able to optimize the best regimen that will work for them, not just in the short term, but in the long term. And at the end of the day, diabetes is a chronic care disease, and the relationship that the patient shares with the doctor, where they feel the doctor is thinking in their best interest, where the trust is there between the doctor and the patient, I think is very key for the patient to kind of engage on a continuous basis and get the outcomes that we both desire.
Right, Dr. Sona. Wonderful thoughts. Thank you very much, Dr. Sona, for your thoughts. It has been wonderful having you here. Thank you for your time.